I don't know if we're excluded into that category in this, the stuff that y'all said in this packet. I thought it was really kind of, I mean, the pharmacist can't prescribe drugs for the patients, and so they expect us, the doctors or other people with a license, to provide her to. But then it kind of defined what establishing a doctor-patient relationship was, and it kind of excluded some of the things that we're talking about.
It did that for controlled substances back in the early part of 2009 in that area, whenever a lot of controlled substances were being shipped in from Florida and other states. It expressly required a in-person patient-physician relationship for the purpose of prescribing controls. So that is something for us to look at from the pharmacy board standpoint, because even if it is legal under the Medical Practices Act, if we broaden this definition, it might be an issue there. Good point.
David, have you seen what other states have done regarding defining controlled substances, including lifestyle drugs?
Well, I didn't see lifestyle drugs anywhere. The normal term, like I said, sometimes it was controlled substance, sometimes it was things like the dangerous kind of euphemistic phrases, like kind of you and I both thought, I think it's very helpful, but controlled substances seems to be the most common. That's, to me, the simplest. But yeah, for the reason you said there's a statutory definition of it.
At a conference I was at, the Nevada representative said they don't allow it except for Viagra.
In Nevada, of all places.
Yeah. You need Vegas.
Just the counties outside. So let's move on to controlled substances. Kevin, I think you've got some direction on how we need to tailor that, and to David's point about where to structure that as exclusions from that definition. Let's move on to the no prescriptions may be issued for a quantity greater than a 14-day supply. Thoughts and comments about that?
Why? Yeah, I agree with that. Why?
I mean, it is arbitrary. I'll say this was actually my suggestion, and my sole reason was that it would be a mechanism to ensure it's followed up with a local provider. At 14 is completely arbitrary. You're correct. It could be 30, 60, 90 for all I know. I just was trying to how do you keep it from being where someone's having their diabetes tested exclusively by themselves at home and getting them metformin refill 365 days a year from their iPad. And maybe that's going to be appropriate.
Yeah, what my see of it is too. One is it seems like one of those things the board's going to be pressured in a few years to change. It makes me a bit more comfortable. The other thing is from a consumer, I can see that something, well, 14 days later, I'm calling you back. I'm calling the same company back, or another telemedicine company.
Well, unfortunately, if you want to prevent that, the way to do it is to make it have primary care provider.
Yeah,
that's what you have to do.
Yeah, I think we addressed it through that.
Or you could address it by just not allowing refills on those prescriptions that are, but maybe that promotes the exact same thing you're talking about, is calling back in 30 days and getting these prescriptions. So I'm hearing some consensus that may not be the best idea.
I think it's necessary to have there and think that it's not possible. They're really around it.
Okay.
Call doctors on call instead of telephone.
Duly noted. Kevin, you got that scratched. The committee thinks that's a poor suggestion. Okay.
That's another problem with the prescription drugs. You can shop around, right? I mean, in the real world, people go to different doctors to get prescription drugs. Why would we theorize that in telemedicine they would do the same thing?
Fair point. Fair point. You're a smart guy.
Well, some of this stuff is just not thought about it in a long time. It's not necessarily smart.
So moving on to the physician shall take an appropriate patient history during initial encounter and keep a well-documented medical record. Now, it's not very detailed as to what that is in terms of what a well-documented medical record is, or what an appropriate patient history is. Although I would doubt that anybody would argue that both of those should have occurred during one of these or any visits.
Yes, but I might add to this, maybe the government and an appropriate physical exam were necessary by using peripherals or something like that. I don't know if you want to have two places, but the concept would be, when you're examining a patient, you take a history, but you also do a physical exam where necessary. So if somebody comes in the office and says they can't breathe, I'm going to take a step to go, and I'm going to listen to that patient. So, I want that to be sort of hammered into this thing, whether we have two places or one place. You understand what I'm saying?
Comments on that?